Tēnā koutou katoa. I'm Jo Simon, CEO of the New Zealand Law Society, Te Kahui Ture o Aotearoa. Thank you all for attending this important event that's part of the Law Society's support for Super Saturday and New Zealand's COVID-19 vaccination program. We know COVID is a worrying time for many people on many levels, and we want to play our part as leaders to protect our vulnerable communities. So in a moment, I'm going to hand over to Grant Pritchard, who will be introducing our panelists and moderating this session. So for those of you that don't know Grant, he's a senior in-house lawyer at Spark NZ, and he's also the president of the In-House Lawyers Association of New Zealand, which is a section of the New Zealand Law Society. And Grant's also an internationally recognised workplace mental health advocate. So thank you, Grant, and look forward to hearing this great discussion.
Kia ora, ngā mihi kia koutou. Welcome all, and thank you, Jo, for that really kind introduction. I am very, very excited to be here today talking to you about a topic that means a lot to me. And judging by the join rate, the sign-up rate for this session, it means a lot to a lot of our lawyers across New Zealand too. So I just wanted to say thanks to Jo and President Tiani Pati and the Law Society for leading out on this topic. This really matters to New Zealand, and it's, vaccination, I think, is a really important part of our COVID response. And as a profession, I think we have a real chance here to be a force for good when it comes to protecting our clients, our colleagues, and our loved ones and the vulnerable around us. And it really means putting the we before the me. It means getting really well informed ourselves about COVID, about the vaccines, and about what we can do to protect ourselves and others. And it means helping the people that we care about to access really reliable, accurate, evidence-based vaccine information. And it also means keeping manaakitanga, kindness and respect and caring right at the heart of our conversations with the people around us who might have questions or concerns about vaccines. I'm really, really stoked today to be joined by Dr. Joan Ingram. So Dr. Joan is an infectious diseases physician and a medical advisor for the Immunisation Advisory Centre. She values and understands the role that immunisations play in our health and our communities, and also by DLA partner and head of employment, Laura Scampion. So she's from DLA Piper, and she's bringing her global experience in employment and health and safety law to this presentation and the discussion. So thank you to you both, and I'm going to hand over right now to Dr. Ingram to share her insights and thoughts around vaccinations. Thank you.
So can you hear me and see my screen? I'll take that as a...
Yes, we can, John.
So tēnā koutou katoa. Thank you very much for the opportunity to speak to you today. First, I'll address why we need a vaccine, and it's been hard for us to realise what's been happening in the rest of the world around us. But we are, as a globe, facing our most severe pandemic in over 100 years. Here you can see the successive waves that the world has experienced, and to date, 239 million confirmed cases have been reported, including 4.8 million deaths. And these are a huge underestimate. People have to be diagnosed and reported to be counted. So the illness COVID is caused by the virus SARS coronavirus 2. And this is a new infection. None of us have met it before. So none of our immune systems are prepared for it. And this is unlike the 1918 influenza pandemic, when some of the older people were partially immune from an influenza virus that had circulated in the 1880s. And so the deaths were higher amongst young, unprepared people. And this illness, none of us are prepared for. It's sneaky. It can be spread by those who are infected before they know they are. And this is quite different from influenza, when generally, by the time you're infectious, you're lying in bed feeling unwell. And there's no doubt about it, it is more serious than influenza. For quite a significant number of people after the infection, there are persisting unpleasant symptoms. And we have seen over and over again around the world that it can overwhelm healthcare systems. And I just read last week that in Melbourne, they had to start to send ambulance staff out in ambulances by themselves because they were just so stretched. This is the first time they've ever done that. We can be sure it will spread throughout New Zealand. So for those of you not in Auckland, you might be feeling that it's a distant problem that will remain with us in Auckland. That is wrong. We've seen over and over in other countries that it might start in a big centre, like the cities in northern Italy with a focus, and it rapidly spread throughout the country. And that has happened, for example, in Suva, it spread throughout Fiji from Suva. And to put it in perspective, last year, COVID was the third leading cause of death in America. So it came from 0 last January as a cause of death to third after heart disease and cancer. To illustrate it further, you can see that the death rate in America last year increased from 715 people per million in 2019 to 829. And this is unheard of, to have such an increase in a decrease in life expectancy. Another way of looking at it is that the life expectancy fell by 1.3 years in America. And that wasn't across all groups equally. Latino, for example, their life expectancy fell by 3 years. So it's a serious illness. We were so lucky here, and I think many people failed to appreciate how lucky we were. Well, fortunate, it wasn't luck. We worked hard, and up until recently, we'd had 2,900 cases, and very few of them locally acquired, as you know. But not now. We have our own outbreak of Delta, and now it's spreading, unfortunately. And I want to explain there are ethnic differences being seen in other countries and occurring here now. You can see that amongst our community cluster, this Delta outbreak, 23% of those hospitalised have been Maori and 60% of those hospitalised have been Pacific people. And this looks at it a different way. This publication shows that Pacific people have 3 times the risk of being hospitalised if infected with COVID compared with the baseline European, and Maori 2.5 times, and that's higher than people with underlying conditions. Similarly, the death rate is higher. So if you look here for a 40 to 59-year-old Maori person, their risk of dying is nearly as high as a 60 to 79-year-old European. So because of this pandemic, the world and New Zealand need to vaccinate. And so we had unprecedented effort from the global community to develop vaccines and had them available in less than 12 months after the first publication of the viral genome last January. It was fantastic effort. And everyone is concerned about the speed of development, but I can assure you the development process was accelerated, but no shortcuts were taken. The massive financial input and the political will made everything be compressed and achieved more rapidly by a huge scientific effort. We now have 7 vaccines being used, and to date, 6.6 billion doses have been given globally. Nearly half of the world's population have had 1 dose, and 37% are fully vaccinated. Pfizer have shipped more than 1.6 billion doses of the vaccine we have to over 130 countries, and I think it's fair to say that it's probably the best vaccine that we have available currently. There are 200 more vaccines in development, And this is a rapidly evolving process. It may be that we need boosters in the years to come. It may end up being an infant vaccine. So it's very much an evolving process. I will just mention that some people are waiting for a vaccine produced by Novavax, but at this point it's still in the trial phase. And there's been, it hasn't been submitted to MedSafe, and it's not in clinical use anywhere in the world. So it is a big step to wait for something that's still experimental, assuming that it's going to be good. A lot of people wonder how our vaccine is made, and it's actually made via bacteria, E. coli, and big vats produce spike protein, DNA. And this DNA is then used to make messenger RNA, which is the complementary pattern. And the mRNA is isolated, purified, and incorporated into a lipid bubble, which is then put in the vial. And the creation of this lipid bubble maintains the mRNA. Without it, it's very unstable. And all that the vaccine contains is this mRNA in the little tiny lipid bubbles, some water and some salts. So you can assure people there are no human products, no live virus, no animal products, no fetal cells involved in the production of it, and certainly no magnets and no microchips. It doesn't give you COVID, nor does it cause a positive test swab. The aim of all the vaccines is to make antibodies against spike protein. And here you can see the spike protein on a diagram of the virus. It sticks out and it has this bit here called the receptor binding domain. And these spikes stick to our ACE2 receptors, which we have on our airway cells. And when they bind, the virus can then enter our cells and infect us. And the ACE2 receptors are found throughout the body in other parts, such as the kidneys. If you have antibodies made in your body that cover up these spike proteins, the virus won't be able to adhere to your ACE2 receptors and infect you. So our vaccine's trade name is Comirnaty. And as I say, it contains this mRNA, which is injected into your arm, taken up by cells there. And basically the mRNA acts as instructions to tell your body to produce lots of spike protein. And the spike protein is then recognized by your immune system and you make antibodies against it. The RNA vaccines don't have anything to do with our genetic material, which is inside the nucleus of the cell. They don't get in there. And the mRNA itself is very fragile outside its lipid bubble and degrades within hours. The lipid is also destroyed and removed from the body pretty rapidly. Some people have concerns about the spike protein, but the spike protein that our cells make is far smaller in quantities than if you are infected with the virus. It is also broken down fairly quickly. However, if you later meet the virus, your immune cells will immediately recognize it and create the antibodies to prevent it infecting you. So this, of course, is very important. Before you want to have a vaccine, you need to know that it will work. This is the pivotal phase 3 clinical trial. And in this trial, 22,000 people in various countries around the world received the active vaccine and 22,000 received a water vaccine, and no one knew who had which. And if you look at the magnified section from down here, you can see after about 10 days, the curves diverge. And these red circles represent cases of positive symptomatic COVID. And there were 77 circles here, 77 patients out of the 22,000 got confirmed COVID, while 850 here of the placebo recipients got COVID. And so that gave a 91% efficacy against infection, whereas black circles show severe cases. So there was 1 severe cases and 30, 1 in the vaccine recipients and 30 in the placebo group. So that gives a 97% efficacy against severe disease. This can be shown in the real world. That was the study, but here's data from America showing that there's a 25-fold reduction in hospitalization and death in those who are vaccinated. And we know, though, that it is less good at preventing infection. So you can see an 8-fold reduction in infection, which is lower than its effectiveness at preventing hospitalization and death. Here's recent data from the UK, which is in the Delta era. And again, the death and hospitalization prevention is still very good. However, preventing any infection is around 75 to 85% effectiveness. It's much harder to make a vaccine that totally prevents any infection than it is to prevent severe infection. We can see this in play now during our Delta outbreak. Here on the left, you see the number of people who have had no doses or their first dose less than 14 days ago, cases and hospitalizations compared with those who have had 2 doses. So this is real world effectiveness with Delta. Safety, of course, is very important. And every vaccine and use goes through a number of stages. These are the ones that were done quickly last year, but they were certainly done. Small phase 1 trials followed by phase 2, then a phase 3 trial, which is the one that I've referred to. But safety monitoring really only begins then. There's a huge amount more that's done once it's in clinical use, and that's called phase 4. And a large part of this is the reports to bodies such as our Centre for Adverse Event Monitoring. So reactions following the vaccine are encouraged to be reported, and they're a good way of identifying concerns, safety signals, and then far more analysis goes on comparing vaccinated with unvaccinated cohorts to ensure safety and to keep an eye monitoring on it. So I just want to make it clear that vaccine adverse events occur in the first 2 months after a vaccine. People are worrying about long-term events. But as I told you, the mRNA and the spike protein are rapidly broken down. And in all vaccine adverse events, they generally occur in the first week or 2 after the vaccine, and 2 months is the maximum time period that you would be thinking a vaccine could cause anything. We know that it can cause allergic reactions, and it is higher than after influenza vaccine, for example, which is about 1 per million. It can cause a sore arm, and it can certainly make people feel unwell for the first day or so. So tiredness or headache are seen in about 1/3. Things like fever and nausea in about 1 in 10. And generally these resolve after 1 to 2 days, but it is worth noting that, about 20% of people miss their usual activities for a day or so, so can't go to school or work. And all these symptoms can be helped with things like paracetamol, and people have to be aware that this is expected and manage it. A few people do get swollen nodes under their arms. That usually doesn't cause any concerns. And I just want to stress that the vaccine is very important for pregnant women, and it's safe for pregnant women, and it has no effects on fertility. The main concern that we have found with this vaccine is inflammation of the heart, or the sac of the heart surrounding it. It's more common in young men, those under 30, and it's more common after the 2nd dose. And generally it's mild and settles pretty quickly, but as you probably know, we have had 1 reported death from this. These are our main reports to date. So the common things that we expect have been reported in large numbers. So I hope I've shown you that the vaccine is highly effective against hospitalisation and death, and it does reduce infection, but not always prevent it. It is safe, and it's really important to protect individuals and their families and communities. Unfortunately, some ethnic groups have a much higher risk of hospitalisation and death from it. I think it is important to encourage everyone who's not vaccinated to get theirs as soon as possible. Delta is here now, and it will be joining the rest of the country soon, I'm sure. So I'm not sure what people are waiting for. Thank you. Oh, I just wanted to point out our website does have a lot of information to look at. Under COVID vaccines in New Zealand, there's useful information, and there are other videos and things like that.
Thank you so much, Dr. Ingram. It's been a great, very fact-based presentation from you, and we're really grateful for you giving your time today. I know you're very busy. You've got a lot on your plate given where we're at as a country, so thank you. And just to encourage everybody, we're seeing lots of questions coming in. We won't be able to answer all the questions, but do keep them rolling in. What I'm going to do is hold those. We're curating in the background, and then at the end we'll just have a quick back and forth with Laura and Dr. Ingram just to answer some of the questions. Some of them are quite specific, and so you might find that if it doesn't apply to large groups of lawyers and Kiwis, we might need to kind of set that to one side. So without further ado, I'll pass over to Laura Scampion. Thank you so much for joining us, Laura. We're really stoked that you could be here, and we can't wait to hear what you've got to say about COVID vaccines and the law. Over to you.
Thank you, Grant, and thank you for your kind introduction. And thank you, Dr. Ingram. Absolutely fascinating. I'm afraid I'm not going to talk about anything nearly as exciting as spike proteins, but hopefully you'll find some of this useful. And lastly, thank you, Joe, and to everyone at the New Zealand Law Society for this initiative, really important. And thanks for the opportunity to come and talk to the profession. So look, over the next 15 minutes, I'm going to take you on a tour of some of the key issues arising for employers in relation to the COVID-19 vaccine. And I'm going to do that really through 6 key questions that the New Zealand Law Society have received and that we've come across in our travels in terms of dealing with vaccinations. The first question really is about 100 combined into one, and that's in relation to government mandated vaccination and employer vaccination policies. So it's generally pretty well understood that prior to the announcement last Monday, the 11th of October, vaccination was already mandatory for high-risk roles, including health worker roles in border and MIQ settings. This was provided for in the COVID-19 Public Health Response Vaccinations Order. Now, by virtue of an amendment to that order announced Monday last week, 2 more workforces have been added. First, certain roles in the health and disability sector are now also covered by the relevant order. So anyone conducting high-risk work in the health and disability sector needs to be fully vaccinated by the 1st of December this year. It's important to remember that that covers both regulated and non-regulated healthcare work. Non-regulated covers aged residential care, and we've seen a huge amount of debate in relation to vaccinations already in that sector. It includes home and community support services, Māori health providers, Pacific health providers, and non-government organisations who also provide health services. The second workforce added to the mandated bucket last week covers schools and early learning centres services. These providers will need to maintain a vaccine register and ensure that only vaccinated staff and support people have contact with children and students. Those workers will need to have their first dose of the vaccine by 15 November this year and be fully vaccinated by 1 January next year. Now, what if an employee or worker is outside those categories that provide for mandatory vaccination that I've just been through? Before an employer can introduce a policy to mandate that a particular role or roles in its workforce must be performed by an employee who is vaccinated, a health and safety assessment needs to be done. Now, I'm going to talk a little bit about health and safety assessments in a few minutes, but first I've been asked to talk briefly about government mandated vaccinations in some other regions across the globe, where we've been working with our colleagues, including the Asia Pacific region. New Zealand's position is in fact quite similar to the rest of the APAC region, with some variations here and there that I'm going to talk through. Contrary to popular belief, there's no mandatory vaccination for employees in China, Hong Kong, Japan, Thailand, or Singapore. There's a couple of interesting nuances in Australia and Singapore. In Singapore, the government has been implementing a vaccinate or regular test, or VORT regime, for employers in selected high-risk sectors, including healthcare, elder care, settings with children under 12, sectors that interact with customers in high-risk settings, so your gyms and your fitness students, your personal care services, public servants, retail mall workers, workers in supermarkets, taxi drivers, driving school instructors, and public transport frontline staff. So a huge list there. Now, under the VORT, the vaccinate or regular test regime, employees in these high-risk sectors are required to vaccinate or undergo regular testing twice a week. So some interesting initiatives there in relation to testing from Singapore. Now, moving closer to home, if we talk a little bit about Australia, Australia have had a similar journey to New Zealand in that mandating vaccination has been a developing story. But Australia, I hasten to add, is significantly more advanced than New Zealand now in terms of government mandated vaccinations. The sectors already covered in Australia by mandatory vaccination orders are what one would expect and now apply across most states in Australia: aged care, disability services, education, including early childhood education, health, quarantine, airport and borders, and construction. But if we move to some of the bigger centres in Australia, New South Wales, for example, whilst the New South Wales government has not expressly announced a policy requiring workers to be vaccinated, it has quietly made it a requirement that in reopening from last week, and we'll all remember Freedom Day last Monday in Sydney, businesses listed in an other category must take reasonable steps to ensure people, including staff, who are not fully vaccinated may not enter the premises, effectively putting in place a mandatory vaccination direction. So the following is in the other category in New South Wales: entertainment facilities. So theatres, cinemas, music, concert halls, recreation facilities, stadiums, showgrounds, racecourses, swimming pools, hospitality, places where a wedding or a funeral might take place, hair and beauty, hairdressers, spas, etc. Indoor recreation centres, so gyms, squash clubs, tennis centres, information and education facilities, retail premises, auction houses, markets that don't predominantly sell food, and properties operated by the National Trust. So if you're in that category in New South Wales, you must take reasonable steps to ensure people, including employees who are not fully vaccinated, do not enter the premises. Now, if we move on to Melbourne, and we've heard Dr. Ingram talk about some of the issues that Melbourne has faced, which have been vast. You could say that some of the initiatives introduced in Victorian workplaces cover almost everyone. And I'd encourage you all to go on to the Victorian Government website and have a look, because the list of occupations there is broad and wide-ranging. But there's some relatively interesting gaps in terms of government mandated vaccinations in Victoria that have really been caused by the drafting of the orders. For example, financial services and law firms are covered by mandatory vaccination orders, but there are no other professional services covered. Some retailers covered, for example, click and collect and stores and shopping centres, but not standalone stores. Now, these vaccination orders in the state of Victoria do lapse on Thursday at midnight, I think, when the state of emergency also lapses. So I think what we'll probably see is a flurry of new directions from the state of Victoria later on this week. So for the avoidance of doubt, both New South Wales and Victoria have relatively broad, far-reaching mandated government policies. Moving on, last but not least, to the Americas. In early September, President Biden announced a 6-part plan to address the COVID-19 pandemic and to increase the number of vaccinated Americans. All private employers with over 100 employees had to ensure that their employees were tested weekly or were vaccinated. Employers also have to provide paid time off to employees to enable them to get vaccinated. Large entertainment venues are called on to require proof of vaccination or testing for any entry. Vaccinations also compulsory for all federal workers. So I think in summary, really, although there's jurisdictions that either have more widely mandated vaccinations for employees or provide for a regular testing regime, New Zealand is not particularly unusual in its approach. And hopefully shortly, we're going to see more government guidance in relation to employees in other sectors other than those that I've mentioned that fall under the mandated regime. So if we now go back to New Zealand and the discussion around mandating vaccinations for staff who don't fall into the government mandated categories, but perhaps where the employer would like to require staff be vaccinated. Now, the New Zealand Business Leaders Health and Safety Forum released results of a survey to the press last night, where close to half the CEOs surveyed were planning to mandate vaccinations for their employees without detailed government guidance in their sector. So it's pretty clear that employers are taking bold steps in the absence of guidance. Now, can it be done? Yes, it can be done, but the employer is required to conduct a health and safety assessment to determine whether a role or roles might put an employee at risk of contracting COVID-19 and transmitting it to others. It's important to remember that there's no test or case law in relation to this yet. There are some cases in the employment jurisdiction dealing with border workers and vaccinations in part, but for the main part, there's no health and safety case law in this area. WorkSafe, though, has helpfully provided some guidance on what the questions are that employers should be asking themselves in the context of the health and safety assessment. Broadly, there's 3 stages to the health and safety assessment for employers that are looking at or considering mandating vaccinations for their employees. The first is to look at a list of questions, and they're relevant questions that have been posted online by WorkSafe, so they're available for anyone to have a look at on their website. First question, how many people does the employee carrying out that work come into contact with? Obviously, if there's very few, there's a lower risk. Many people, much higher risk. Second, how easy will it be to identify the people whom the employee comes in contact with? Fairly common sense in terms of what's high risk and what's low risk. How close is the employee carrying out the task in proximity to other people? Again, fairly common sense that if it's lots of proximity, very close for individuals, then your risk goes up. How long does the work require that the employee is in that close proximity to other people? Does the work involve regular interaction with people considered at a higher risk of severe illness from COVID-19, such as the elderly or those who have an underlying health condition? What is the risk of COVID-19 infection and transmission in the work environment when compared with the risk outside of the work environment? Will the work continue to involve regular interaction with unknown people? Now, once going through this list of questions, that I would encourage employers to add any other relevant questions to their risk assessment that are relevant for their working environment, then an employer should record those results. An employer is then required to take a second step in terms of looking at whether or not other controls, other than mandatory vaccination for employees, could deal with the risks. So identifying any further infectious disease controls that the employer could put in place to control those risks. And we've got detailed information as to what many of those controls are. Anything from improved hygiene standards, social distancing, even working from home. As a third step, employers are guided to assess the results of that risk assessment and to work out whether those extra controls are actually going to be enough to alleviate the risk, or they do need to consider a mandatory vaccination policy. So if the outcome indicates that there may be a high risk for employees of contracting and transmitting COVID-19, then mandating vaccination may in fact be the option that employers will move to. So the second question that we're seeing come up in a fair amount is whether or not an employer can ask employees whether they are vaccinated. And the answer is yes. And in fact, what we are seeing is many employers that we are working with have already conducted surveys or are about to conduct surveys or are drafting surveys to be rolled out in their workplace in order to understand the risk in their workplace, i.e. how many workers they have or employees they have that are not vaccinated. Now, employees don't have to disclose or prove to their employer that they've been vaccinated or why they're unable to be vaccinated or indeed have chosen not to be vaccinated. If workers do not tell an employer what their vaccination status is, employers can assume that those workers are unvaccinated, but they should inform workers or employees first of this assumption. The third key question that we're coming across is whether or not it's okay to ask a candidate whether they are vaccinated during a job interview. Now, the guidance says that businesses can only ask candidates if they're vaccinated when this is justified by the requirements of the role. For example, if an employer or business decides, following that COVID-19 risk assessment that I just went through, that certain work cannot be performed by an unvaccinated worker or employee, it may be reasonable to ask about the applicant's vaccination status during the interview. Obviously, the information will need to be collected and handled in accordance with the Privacy Act. The fourth question that we're seeing come up a fair bit is whether or not an employer can advise prospective employees that if they want the job, they have to be vaccinated. Now, employers can require vaccination as a term of new employment agreements. And indeed, what we're seeing is employers seeing that as an easier win than in fact changing current terms and conditions by requiring vaccination of an existing employee. However, it still has to be reasonable for the role. For example, required for health and safety reasons. It also cannot be unlawful discrimination under the Human Rights Act. The fifth question, what are the options for workers concerned about unvaccinated employees? Now, this is going to come up for many employers. What's been interesting in New South Wales is we've seen rules being introduced that deal with this very issue. In New South Wales, an employer must allow an employee who is fully vaccinated to work at home if it's reasonably practicable for them to do so. An employer must also require an employee who is not fully vaccinated to work at home unless it is not reasonably practicable for them to do so. An employee who is not fully vaccinated must not work at the regular place of work unless it is not reasonably practicable for them to work from home. So interesting there, we've got reforms and orders introduced by New South Wales that are really relevant to combining vaccinated and unvaccinated employees together. In New Zealand, the guidance states that workers have the right to stop work or to refuse to carry out work if they believe that doing the work would expose them or anyone else to a serious risk to health or safety from an immediate or upcoming hazard. However, guidance is also pretty clear that unless vaccination is needed for health and safety reasons, work is unlikely to be unsafe solely because it is done around unvaccinated workers. I'd go on to say that if an employer has carried out a health and safety assessment and has deemed that in fact vaccinated and unvaccinated workers working together in the workplace is safe, then it will be difficult for an employee to assert that they indeed cannot attend that workplace or work environment. Last but not least, we are often asked about the Bill of Rights, and it's certainly relevant in relation to vaccinations. Under the New Zealand Bill of Rights Act, vaccinations are considered a medical treatment and therefore require informed consent. What we're talking about in terms of employer policies and introducing mandated vaccinations into the workplace is not forcing medical treatment, but rather requiring vaccination for the performance of a role. Therefore, the question really becomes whether the fact that an employee is not vaccinated genuinely creates a health and safety risk that the employer cannot accommodate. Now, that was a whistle-stop tour of vaccinations and government mandated vaccinations. I think I'm handing back to you now, Grant, for some Q&A.
Kia ora, thank you. Gosh, that was a that was a quick romp. Thankfully, this is being recorded because I couldn't keep up. But great insights there. Very practical. Thank you, Laura. So what we're going to do now, we've had dozens and dozens of questions, so I've been just trying to sift my way through them. So thank you so much if you've taken the time to ask a question. We won't be able to get to them all now, but I just love the level of engagement here. So do feel free to continue these conversations, and just remember to seek out really good local sources for your vaccine-related information that you can rely on. And that's the key thing, is that we need to be able to rely on the fact that we're getting good, clear evidence-based answers. So I'm just going to back and forth a little bit now with Dr. Ingram and Laura just on some of those key questions that have come through. And apologies again if we can't get to your question. So Dr. Ingram, your first question for you is just talking about individuals who can't have the Pfizer vaccine, for example, because of a specific health reason. They might have an allergy to one of the ingredients, for example. What's the portion of the population that genuinely can't take the vaccine, either because of an adverse event or because of their own allergy to an ingredient? Were you just on mute, Dr. Ingram? Sorry.
Sorry, I had thought I'd need to remember to unmute, but then I didn't. The number of people who can't have a first dose is very small. Those with the allergy to PEG are a small group, and we hope to have an alternative vaccine available before too long. There was one coming, but now it's been delayed, unfortunately. Then after the first dose, some people can have an allergic reaction to it, and initially we thought they shouldn't have a second dose, but now immunology clinics are seeing them and carefully vaccinating them usually. There are a small number of other people who might have a adverse event such as the heart inflammation after their first dose, so it's not advised to have a second dose. So again, we're collecting a list of people for whom an alternative vaccine is a better idea.
Thank you. Thank you. And Laura, so you may have partially covered this during your part of the session, but this might bring out some different perspectives as well. So if an employer doesn't take specific steps, for example, they're allowing unvaccinated clients and customers to sort of wander through the premises, they might not keep a safe distance between desks and workspaces. Can the employee refuse to return to work at the place of employment and maybe work from home if they're able to do that?
Yeah, good question, Grant. And yeah, I did cover that in part during the 15-minute roadshow. But look, for a long time, it's been the law that an employee can stop work if they believe that doing the work would expose them or anybody else to a hazard or risk. So if no precautions are being taken by an employer, say, there's no level 2 social distancing rules, there's no improved hygiene standards or so on in a workplace, then yes, arguably an employee can stop work or ask to work from home to refuse to attend the premises. In saying that, like I said before, if the employer has carried out a robust health and safety assessment, they may have got an independent operational health and safety expert in to advise, and that has said that actually we've adequately minimised the hazard and risk here, then it will be difficult for an employee to assert that the workplace is unsafe. What I would encourage in these situations is open and constructive dialogue, i.e., what about our workplace is not safe? What can we do to fix this so that you can attend and so that you do feel safe? And alternatively, the compromise, which is allowing people to work at home if they don't feel safe coming into the work environment.
That's great. Thank you. That's really helpful, Laura. So, Dr. Ingram, what resources are available that would help lawyers who you may have friends or family, you may have clients, you may be representing somebody who's got either a hesitancy to the vaccine or is really against either vaccines in general or specifically the COVID vaccines or the Pfizer vaccine. What resources are out there that might help?
Well, the Ministry of Health website, of course, has information, and our Immunisation Advisory Centre has a lot of information at various levels. So there's simple videos, there's a lot of translated information, and there's also more detailed information on the vaccine with links to various resources. So it is a good starting point. There are some people that are doing, like there's an Instagram person, Morgan Edwards, who has good information. But there is the big issue that sensational, incorrect things get clicked many more times than sensible advice and information. So people do have to pick where they get their information from.
Great to hear as well that social media isn't all bad. But I do understand that, you know, misinformation is contagious too. So we just need to be mindful of that, right? You're actually protecting yourself from being taken advantage of in some cases by incorrect information that maybe coming from someone that hasn't got your best interests at heart too. So thank you, Dr. Joan. And so the next question I've got for Laura is, could sharing vaccine misinformation in some circumstances and in certain workplaces potentially amount to misconduct in a workplace environment?
Thanks, Grant. Yeah, we're getting a lot of this. So look, I have to say, and Dr. Ingram could probably pop in here and add some value, but before any vaccine is approved for use in New Zealand, it has to meet international standards and local requirements for quality, safety and efficacy. So I think we need to all play our part, and you've just alluded to this, Grant, by relying on trustworthy information about vaccines. That said, we do come across those who are spreading information that may not be reliable or indeed trustworthy, and there is obviously a chance that that is going to happen in the workplace at some stage. Many individual employment agreements now contain definitions of misconduct, such as endangering the health and safety of somebody else or bringing an employer into disrepute, providing that an employee must act in good faith towards the employer, that the employee must maintain high standards of integrity and professionalism. So depending on what is said, how it's said and who that's communicated to, whether it's posted on an intranet for 500 people to see and it's absolutely scathing, or whether it's just personal information shared across the desk as to someone's opinion, that's going to be relevant. So yes, arguably it could be misconduct if that is being shared, but I think that circumstance in relation to that would be very rare. I think what we'd see mainly is people really exchanging opinions in relation to the vaccine. So would urge anyone to seek legal advice before jumping into on the misconduct bandwagon about misinformation on vaccines.
Thanks, Laura. Dr. Ingram, another topic that's often coming up, this is a bit of a multi-pronged question, is things like waning of efficacy of vaccines over time, protection against retransmission of the virus once you do get infected with it, and the timing or need for booster shots. These are just real things that we're encountering now that we're in the middle of this big rollout, and people like my parents, for example, are due to potentially get a booster shot in January. I think it'd be good to hear your thoughts on those three topics of efficacy, protection against transmission and booster shots.
Okay, well, those are big questions, and
just in a sentence or two, if you could.
Yeah. Rapidly evolving area, and probably a lot of people are aware that boosters are now being given in some countries USA and UK and Israel. And so the first group that will need boosters are those who have impaired response to the first vaccine. So that is immunocompromised and very elderly. When I'm talking about protection against from the vaccine, not everyone is protected the same as others. So if you have an impaired immune system or if you're elderly, the vaccine is less effective in you. And we've seen that in the real world data. So they are the first people that will need boosters. I think it's fair to say that for the general population, the need for boosters is still uncertain. There was a lot of controversy in America when they said that they would boost healthcare workers because of their risky positions, risk of catching the virus. The data wasn't really supporting that. It really supports it for very old people or immunocompromised people. But it's a rapidly evolving field, and most people think, like influenza, we will need repeated vaccinations, not necessarily just because of waning immunity, but also because of the vaccines. Viruses are sneaky and they keep changing on us. So that's also a factor to remember.
Sneaky viruses.
Yeah, as far as transmission goes, we know that people are less likely to catch the virus. They also appear to be less likely to spread it. I've got a study that I've just read from Sweden where the risk of somebody getting infected in a household, if there were 5 other people in the house and all the others were infected, was a very low risk of that person in that house getting COVID. And we saw it ourselves here in Auckland at the beginning of this outbreak. There was a nurse who worked 4 shifts at Auckland Hospital. She was fully vaccinated. She had proven COVID, but no symptoms. And all the staff that she interacted with for 4 shifts and the patients were carefully checked for swabbed repeatedly. The ward was locked down and everyone was checked, and she hadn't spread it to anyone in her 4 shifts. So that is proof of it's reducing spread.
That's awesome. Thank you so much for sharing on that. And a last question now for Laura. We're getting close to time. I think we could talk all afternoon on this. I'm absolutely fascinated and I feel like we've really learnt heaps. So have you got any tips, Laura, for encouraging and motivating employee vaccination within the workplace environment?
Yeah, and look, we're seeing quite a bit of this from employers that don't want to mandate vaccination for their employees or don't consider it appropriate. They're embarking on big motivation or encouragement strategies for their employees. So some of those is, provide information to your employees, but don't overwhelm them. There's so much information, as we've heard today, and Dr. Ingram obviously has far more than she's presented today. You've got a whole lot of information, Grant. I've got a whole lot. So it's important not to overwhelm employees with all this detail. So if we do overload employees with too much detail, it simply paralyzes them and it could decrease vaccination rates. So providing simple and easily understood information about why, how, and perhaps where they can get vaccinated can be useful in terms of motivating employees to go off and get vaccinated. Making it easy is really important. Providing some paid time off. Look, the number of employers we come across where employees have said, well, I didn't understand I could go and have the afternoon off. Equally, as Dr. Ingram has just pointed out, particularly after the second vaccination, employees can feel a little bit unwell. Making sure that they're aware that they can take some sick leave if they do feel unwell after a vaccination or, a couple of days after. So facilitating appointments is something that we're seeing as well. So employers actually making sure that the website is accessible, facilitating those phone calls and making sure that they can get appointments for staff to go along and get their vaccination. Having workplace champions, really important. So those people who are really positive, speaking about it openly, whether they're speaking to someone who's a little bit hesitant about the vaccine or speaking to someone who loves the idea of vaccination, making sure that there's a really cool dialogue in your workplace, which for Aucklanders is a virtual workplace, but hey, we can still have champions virtually. Using social networks. So it's interesting that employees often feel comforted knowing what other employees are doing. Now, that's quite hard if you're in Auckland or other lockdown regions when you're not seeing each other. So making sure, again, that there's some type of communication, a social network between your employees that makes vaccinations okay, safe and accessible. Just a few
Brilliant.
tips, Grant.
Oh my goodness. Okay, good. Luckily, as I say, luckily we're recording this. Thank you so much, Laura. And Dr. Ingram, one last question for you. Just on, obviously there's a number of different vaccines out there. We've gone with Pfizer for our first wave of vaccinations here in New Zealand. I understand that Novavax is currently being evaluated and may be introduced for things like booster purposes. Can you just talk through at a level that I'll understand, so dumb it down to the 5-year-old level, what the kind of difference is between a Novavax type vaccine and the Pfizer or Moderna type vaccine?
Yeah. So actually it's not been assessed by MedSafe at the moment. MedSafe's waiting for information from the manufacturer. So
there's some misinformation from me.
Bit of a wait and see there. But the Novavax is using, so the Moderna and Pfizer are messenger RNA vaccines, which I talked about. So it is a new technology. The Novavax is using an old technology of just a protein subunit. So it's making a bit of spike protein and giving you a bit of spike protein. Our hepatitis B vaccine that infants get in the first year of life is a protein spike vaccine, a protein vaccine. So you're getting a little bit of surface protein of the hepatitis B virus in that vaccine. So it's using an old method, but it's taking a lot longer to develop. The beauty of the mRNA vaccines is the speed that you can make batches of it. It's quick to produce, unstable, so it has to have the very cold freezer, but the Novavax technology is slower. And
wonderful.
proven.
Thank you so much. I feel like I'm better informed and better equipped. Both of you have just been really great today, and I know you're very busy people. I'm really sorry we can't answer all of the questions, but just a big thank you to Joe and Glenda and the New Zealand Law Society team for standing up this session. I think it's important for us as lawyers to step up, to play our role. We all have a role to play, even just in listening, listening, being respectful and just learning together about this stuff. And as I say, keeping that manaakitanga at the heart of things. So thank you for joining us today. I hope you enjoyed the session and we look forward to talking again soon. Thanks everybody. 2,000 people on the call today. That's 1 in 8 lawyers in New Zealand joining us for the session. So unbelievable. Thank you so much.